Bismillahirrahmanirrahim. Assalamu alaikum everyone. My name is Dr. Khusham Amjad, and today the topic of my presentation is acute febrile viral illness. So first of all, I'm going to talk that why I chose this topic. Acute viral illnesses are among the most common clinical presentations worldwide. They have high morbidity and mortality. AVI, especially respiratory infections, account for a substantial percentage of child mortality in Pakistan. 20 to 30% of deaths in under 5s. Local disease burden in Lahore. Lahore, being a densely populated metropolitan area, experiences seasonal and epidemic outbreaks of viruses like dengue, influenza, and various respiratory pathogens. Antimicrobial resistance crisis. Rampant and inappropriate use of antibiotics for viral illnesses in Pakistan is a major driver of global AMR. Next, I will talk about need for awareness. To educate healthcare professionals on current local trends, correct diagnostic pathways, and evidence-based supportive care to improve patient outcomes and reduce inappropriate antibiotic use. Now let's talk about the learning outcomes. By the end of the presentation, participants should be able to identify the major acute viral pathogens circulating in Pakistan, understand the general pathogenesis of common AVIs, understand the general pathogenesis of common AVIs including respiratory infections, gastroenteritis, outline the major investigations to support a viral diagnosis and rule out bacterial infection, detail the evidence-based supportive and specific management strategies for common AVIs, and advocate for appropriate public health measures including vaccination in the local context. Defining acute viral illness. What is an acute viral illness? A condition caused by viral infection typically characterized by rapid onset and short course from days to weeks, often resolving completely. Acute means rapid onset and short course, typically spanning from days to weeks. Viral means caused by a virus that infects a host cell to replicate. And illness manifests as a collection of signs and symptoms. Common syndromes in Lahore include acute respiratory infections, which further include common cold, influenza, COVID-19, bronchiolitis. Acute gastroenteritis includes viral diarrhea caused by norovirus and rotavirus. Acute febrile illnesses include dengue virus, measles, and chikungunya. Here I would like to add one more thing. In Chughtai healthcare, in our 17 clinics across Punjab, we see almost 1,000 patients daily. And out of those 1,000, almost 1/3 are related to acute viral illnesses. Now let's talk about the major viral pathogens in Lahore. First comes acute respiratory viral illnesses. The key pathogens are influenza A and B, RSV, HMPV, SARS-CoV-2, and adenovirus. Their peak seasonality is in winter and spring. Acute gastroenteritis is mainly caused by norovirus and rotavirus. Their peak seasonality is year-round, often increase in summer and monsoon season. Acute febrile illness includes dengue virus serotype 1 to 4. Here I would also like to share one more thing. The NIH said that in Pakistan, in 2024, 70,000 dengue cases were reported. And the main serotypes causing dengue in Pakistan are DEN 2 and DEN 3. And the peak seasonality of dengue is in post-monsoon and autumn season. Now I would like to share some key data and reports. Lahore viral illness surge. Hospitals and clinics report hundreds of patients over 3 weeks with high fever, persistent cough, and body aches. Doctors suspect possible COVID-19 resurgence, but note COVID testing has sharply declined in public, private labs, and health department. NIH statement on COVID-19 influenza. NIH has officially denied a sharp surge in COVID-19, saying current increases in respiratory illnesses are consistent with seasonal flu or influenza. In Karachi Dow Hospital, among patients presenting with cold cough symptoms, approximately 25 to 30% tested positive for COVID-19. Also, 10 to 12% had influenza. Human metapneumovirus. NIH confirms that human metapneumovirus has existed in Pakistan since 2001 and has caused outbreaks mostly in children. An example in Wah Kent, out of 113 sentinel samples, 2 samples tested positive for HMPV. From one report, 327 HMPV cases recorded in recent reports, up from 225 the previous year. Now let's talk about pneumonia and viral infection in children. At Lahore Children's Hospital, about 40 to 50% of children under treatment for chest infections tested positive for viral pneumonia. Infants under 1 year old are especially vulnerable. Many cases correlate with comorbidities and suboptimal vaccination feeding practices. Public health responses. In Sindh, the government has ordered increased surveillance, especially in healthcare facilities, and public awareness campaigns for flu. In Rahim Yar Khan district, health authorities issued advisories concerning HMPV after reports of influenza-like illness, shivering, fever, and cough. Now let's talk about possible causes and contributing factors. Based on the pattern and expert commentary, these are being considered. COVID-19 resurgence could be the cause. Other respiratory viruses such as influenza, common cold virus, or others like RSV or metapneumovirus. Reduce surveillance, lower testing rates because fewer people are getting tested for COVID nowadays, and health systems have relaxed routine screening. Detection and response are hampered. Behavioral and environmental factors also play a major role. The usual ones are crowding, poor ventilation, mask usage relaxed, possible air pollution or smog contributing to respiratory susceptibility. Now let's talk about the impacts and risks. Increased disease burden on clinics and hospitals. More people attending with respiratory symptoms can strain the outpatient and hospital resources. Risk of spread, especially among vulnerable groups such as elderly, immunocompromised, people with lung conditions. Risk of mismanagement. Misuse of antibiotics, which is a major issue. If people or physicians treat as bacterial infections, could lead to antibiotic resistance. Potential for a more severe wave if a new COVID variant is involved, especially if vaccine or prior infection immunity is not sufficient. Now, here are the most common presentations. First of all is high-grade fever. The patient comes with high-grade fever, which is sudden in onset, often the first symptom, and it lasts 2 to 4 days on average. Next comes is persistent dry cough. It may begin with throat irritation. Some patients report deep chesty cough resembling bronchitis. It can linger beyond the fever phase up to a week or more. Then comes severe body aches or myalgia. It is described as bone pain or crushing tiredness by patients. It affects daily activities, more pronounced in adults and the elderly. Then comes fatigue or lethargy. It is common during and after fever subsides. Some report feeling wiped out for several days. After that comes sore throat. Often occurs early, sometimes before cough, mild to moderate in intensity, may be mistaken for strep throat in children, though it is viral in nature. Headache is common but not universal, often occurs with fever. Nasal congestion and runny nose is less prominent than in common colds, but still seen in some cases. Some cases involve post-nasal drip, leading to dry cough. Less common or variable symptoms include shortness of breath, nausea or mild GI upset, loss of smell or taste, mild chest discomfort. Now let's talk about the investigations. For COVID-19 testing, PCR test is gold standard. Rapid antigen test is useful in outpatient and or emergency settings. Influenza antibody test includes rapid influenza diagnostic test through a nasopharyngeal swab. RT-PCR for influenza is more accurate, though it is costlier and less available. Respiratory viral panel, if available, detects multiple respiratory viruses simultaneously: RSV, human metapneumovirus, adenovirus, parainfluenza virus, rhinovirus, or enterovirus. Often available only in tertiary hospitals or private labs. Next investigation is CBC. It is useful to distinguish between viral and bacterial infections. Leukopenia or normal WBC count suggests viral infection. Lymphocytosis commonly seen in viral infections. Elevated neutrophils may suggest bacterial superinfection. CRP is mildly elevated, often seen in viral illnesses. Markedly high CRP or rising trend may suggest secondary bacterial infection. Next investigation is chest X-ray. The indications of chest X-ray are shortness of breath, persistent high fever, abnormal auscultation findings such as crackles, elderly or immunocompromised patients. The findings, if the lungs are clear on chest X-ray, it suggests viral etiology. Patchy infiltrates or consolidation may suggest viral pneumonitis or bacterial pneumonia. Next comes pulse oximetry. It is important to check SpO2 in patients with cough plus dyspnea, chest discomfort, no lung or heart disease. SpO2 less than 94% is a red flag. It may require further workup or oxygen. Blood culture. If a patient is febrile for more than 3 to 4 days, it helps detect bacterial co-infection, especially if patient is not improving with supportive care. Urine analysis, procalcitonin selective. Procalcitonin may help distinguish between viral and bacterial cause, especially in borderline cases. If the procalcitonin values are less than 0.1 ng per ml, then it suggests a viral infection. And if it is more than 10 ng per ml, it suggests a serious bacterial infection. Urine analysis is done to rule out UTI, which may mimic fever and malaise in elderly. Next, throat swab or culture are optional. It is done to rule out group A step in patients with predominant sore throat. It helps avoid unnecessary antibiotics if viral cause is confirmed. Here is the summary of investigations. The basic tests include CBC, CRP, rapid COVID flu test, and in moderate or severe cases, CBC, CRP, chest X-ray, COVID, flu, pulse oximetry. And in hospitalized patients, full viral panel, ABG, cultures, inflammatory markers are usually done. Now let's go to the management. The general principles of management are that it should be treated as a viral respiratory illness unless proven otherwise. Avoid antibiotics unless secondary bacterial infection is suspected. Focus on relieving symptoms, ensuring hydration, and monitoring for complications. Encourage isolation or reduce contact during the acute phase. In viral infection, symptomatic treatment is very important. If the patient has fever or body aches, we can prescribe them paracetamol, 500 to 1000 mg every 6 to 8 hours. Maximum dose is 4 grams per day. We could also prescribe them ibuprofen, 200 to 400 mg every 8 hours, if there is no contraindication. In case of cough or sore throat, salt water gargles can be advised. Cough syrups can be given, or lozenges or throat sprays for sore throat. In case of nasal congestion or runny nose, antihistamines are prescribed, and saline nasal spray or mild decongestants can be given. Steam inhalation is also prescribed in this case. In case of fatigue or weakness, patient is advised to rest and hydrate properly. He is advised to take light meals. Patient is also encouraged to take good sleep. Multivitamins can be given, they are optional. Vitamin C, D, zinc, these supplements can be prescribed to the patient. Now, when to consider antiviral treatment? Depending on the suspected or confirmed virus, antivirals may be considered in moderate to severe cases or high-risk patients. For example, in influenza virus, antiviral oseltamivir, known as Tamiflu, is indicated within 48 hours of symptoms, or in elderly, comorbid, or pregnant or immunocompromised patients. In case of COVID-19, remdesivir or Paxlovid is indicated in high-risk patients who are above 65 years of age and have comorbidities. It is only given in confirmed cases. RSV, only supportive treatment is given, no antiviral currently recommended in adults. Next comes home isolation and public health measures. Recommend self-isolation for at least 3 to 5 days from symptom onset. Use face masks if in shared spaces. Emphasize hand hygiene and cough etiquette. Avoid attending work, school, or large gatherings while symptomatic. Next comes monitoring and red flags. Advise patients to seek medical attention if they develop fever for more than 4 to 5 days or recurring fever. If there is any difficulty in breathing or shortness of breath. If there is any chest pain, if there is dizziness or altered mental state. If the patient complains of persistent vomiting or inability to drink. Or if the SpO2 falls below 94% on pulse oximeter. These are all red flags. Next comes hospital-based management, if required, for patients with severe respiratory distress, oxygen saturation less than 93 to 94%, or elderly with comorbidities, suspicion of pneumonia or sepsis. Management may include oxygen therapy, IV fluids, chest X-ray or CT scan, empirical antibiotics if secondary bacterial pneumonia is suspected. Steroids such as dexamethasone in hypoxic COVID-19 cases are also given. Antivirals can be given if indicated and available. Now, what to avoid? Unnecessary antibiotics should be avoided. They contribute to resistance and offer no benefit in viral illnesses. Steroids in mild cases can suppress immunity and worsen viral replication. Overuse of cough suppressants can impair clearance in productive cough. Now, let's talk about dengue fever. This is a local concern. Dengue virus in Lahore is an endemic and epidemic. Dengue is a major recurring acute viral illness in Lahore and Punjab with significant outbreaks, often following the monsoon season, which ranges from September to November. It is usually transmitted by Aedes aegypti mosquito, and the clinical presentation ranges from asymptomatic to severe dengue hemorrhagic fever shock syndrome. Its symptoms usually include fever, abdominal pain. In severe cases, can also happen, and the patient complains of retroorbital pain as well. Public health response, intensive vector control and surveillance are continuous necessities due to the urban environment. Now let's talk about the pathogenesis related to some common antiviral illnesses. Entry and primary replication. Virus enters the host via a portal. It could be respiratory, gastrointestinal, mucosal, or skin break, and replicates locally in susceptible cells. For example, influenza virus hemagglutinin binds to sialic acid receptors on respiratory epithelial cells. Innate immunity response. Local infection triggers interferons, natural killer cells, and inflammation. This often causes the initial flu-like symptoms such as fever and malaise. Tissue tropism. Viruses exhibit affinity for specific tissue tropism determined by the presence of specific cell surface receptors. Systemic spread. For systemic diseases, dengue, measles, the virus spreads from the initial site. It is known as viremia. Most common route is via the lymphatics into the bloodstream, allowing dissemination to distant target organs. Cellular injury and disease. Direct cytopathic effect. Viral replication leads to cell damage and lysis, which is breakdown of respiratory epithelium in influenza. Immunopathology. Host immune response causes significant damage. The cytokine storm in severe COVID-19 or the plasma leakage, which happens in dengue, are due to immune activation. Dengue as an example. Mosquito bite introduces the dengue virus. Primary replication in local dendritic cells or macrophages. Viremia virus spreads via lymphatics to the blood. Target cells, infection of the monocytes and macrophages throughout the body occurs. And in case of severe dengue, which is also known as dengue hemorrhagic fever or dengue shock syndrome, often seen in secondary infections, massive release of vasoactive mediators and cytokines occurs, which increases the vascular permeability and which further leads to plasma leakage and shock. The management, the cornerstone of AVI management is rest, reduce metabolic demand, and aids immune function. Hydration crucial for AVI, especially those with fever, vomiting, or diarrhea. ORS solutions can also be given for gastroenteritis. Symptomatic relief is the mainstay of treatment in acute viral illness. In case of fever or aches, paracetamol is a drug of choice. NSAIDs such as ibuprofen should be avoided in dengue due to bleeding risk. Decongestants or cough suppressants for upper respiratory symptoms should be used. The antibiotic misuse crisis is a major problem. Antibiotics should not be prescribed for acute viral illnesses. Report indicates rampant use of antibiotics for undifferentiated febrile illnesses in Pakistan. Crucial message is that acute viral illnesses do not respond to antibiotics. Inappropriate antibiotic use leads to selection pressure, which further leads to development of antimicrobial resistance. Thorough clinical assessment and rational use of labs such as CRP or procalcitonin should be done to rule out secondary bacterial infection before prescribing antibiotics. Now let's talk about the prevention. What should be the public health strategies to prevent it? First comes vaccination. For example, in case of influenza, seasonal influenza vaccine is highly recommended for high-risk groups, healthcare workers, elderly, those with chronic illnesses. In case of measles, essential to maintain high coverage in the national immunization program to prevent outbreaks. In case of COVID vaccine, it can be given to boost, and the campaign should be boosted based on local recommendations. Vector control. For dengue, aggressive community-based campaigns to eliminate stagnant water, which are the breeding sites for Aedes aegypti mosquito, are vital, especially before and during the monsoon season. Hygiene and sanitation are very important. We should promote regular hand washing, respiratory etiquette, coughing into the elbow, and safe food-water consumption to reduce norovirus rotavirus. Now let's talk about the latest research and future directions. Emergence of HMPV. Recent reports from Pakistan suggest human metapneumovirus is a significant respiratory pathogen circulating, highlighting the need for broader viral testing beyond just influenza and COVID. Expansion of multiplex PCR assays in tertiary centers to rapidly identify multiple pathogens such as flu, RSV, HMPV, adenovirus to guide clinical decisions and reduce antibiotic use. Novel vaccines, development and future introduction of RSV vaccines for maternal and older adult immunization, and potentially a dengue vaccine, Dengavaxia, pending local approval and WHO recommendations based on seroprevalence. Now let's go to the conclusion. Acute viral illnesses are major, often seasonal cause of morbidity and mortality in Pakistan generally, particularly dengue, influenza, and other respiratory pathogens. Local data confirms that viruses like RSV, influenza, and dengue require continuous surveillance and targeted public health interventions. The primary management strategy for most AVIs remains supportive care, which includes hydration and antipyretics. The take-home message is that think viral and act supportive. Stop the misuse. Do not prescribe antibiotics for an uncomplicated acute viral illness. Use lab markers such as CRP and procalcitonin to rule out bacterial superinfection. Monitor the vitals. For dengue, prioritize strict fluid management and watch for warning signs of plasma leakage. Vaccinate. Promote and ensure timely immunization for influenza, measles, COVID for all eligible individuals. Hygiene habit. Reinforce basic hygiene and environmental control, especially for dengue and enteric viruses. Thank you.